Hello, welcome to Oncology Watch, Genomic Assays and Breast Cancer presented by Dr. Sara Robinson. Thank you for joining us today. Welcome, Dr. Robinson. Dr. Robinson is a medical oncologist with our Rocky Mountain Cancer Centers in our Longmont office. We've been fortunate to have her with us for 7 years. And while she sees patients with any type of cancer, one of her special interests is in breast cancer. Her philosophy on treatment is patient-centered. She combines cutting-edge medical knowledge with a holistic and individualized approach for each patient. We look forward to learning more about genomic assays from you, Dr. Robinson.
Thank you, Jessica.
Sorry. Yeah.
Oh, no, go ahead.
We'll be monitoring comments in the comments section during her talk. If you have any questions, please put them in there, and then we will ask Dr. Robinson at the end of the meeting. So we'll go ahead and move forward. Thank you so much.
All right, everybody. Thank you and welcome. I'm going to share my screen here so we can start my slideshow. Oh, wait, I don't want to do that yet. Hold on one second. There we go. Just hold on one second. I need to get it to the slideshow here, which I didn't do.
That's all right. Technology is our friend until it's not.
Let's see if I can do it now. Okay. Great, here we go. Okay, everybody should be seeing the first slide. Is that good? All right, excellent. So welcome everybody. Thank you for joining. So we've put a lot of discussions together this month in regards to breast cancer because October is Breast Cancer Awareness Month. So I encourage you to watch all of the presentations given this month as they're all full of information. We tried to pick things that patients ask questions about the most. So today I'll be discussing genomic assays and breast cancer. And once we start getting into more of the details, I think it'll make sense. There's a lot of questions about this in the curative setting. So this relates to questions about chemotherapy and endocrine therapy in the neoadjuvant and adjuvant setting. Okay, so key points we're going to be talking about today are background of genomic assays, what are they, and how they're incorporated into the treatment of breast cancer. I'll briefly be talking about some data, but we won't get bogged down in that. Mostly I just want to highlight some of the key points and then how the genomic assays impact treatment recommendations. So a little bit of background on genomic assays. So prior to the development of these analysis, and we'll talk about exactly what that means, any woman with node-positive breast cancer or really a breast cancer over a centimeter was recommended to have chemotherapy. So we know now that we didn't know before that many women were overtreated. And the most common genomic assays we use currently in the United States are Oncotype and MammaPrint. There are several others which we'll briefly touch on and their utility, but this is predominantly what I'm going to be focusing on today. So based on genomic assays, now we treat predominantly by the biology of breast cancer and not as much by anatomical staging. So just because someone has node-positive disease, that does not mean they have a breast cancer that's aggressive enough to warrant chemotherapy. There are caveats to this, of course. There's always fine-tuning, especially when you specialize in these types of cancers. So most data with genomic assays is in hormone-positive breast cancer and not triple-negative breast cancer or HER2-positive breast cancer, although we can gain some data with these malignancies if we need to. So in hormone-positive breast cancer, this is where it becomes important for us to distinguish a more aggressive cancer from one that is slower growing. And this has impacts on the benefits of chemotherapy versus toxicity. So what are genomic assays? That's probably really the burning question that we all have. So these are tests that analyze a sample of the cancer tumor to see how active genes are. The other name for it is called a gene expression analysis, and we use a preserved tumor, either by biopsy of the primary tumor or using the final pathology at the time of surgery. Genomic tests look at the activity level of certain genes and how they affect the behavior of a cancer. So how likely is that cancer to grow and spread? And we use this to understand the biology of a breast cancer and the best treatment approaches, whether that be chemotherapy with a combination of endocrine therapy or endocrine therapy alone. There are many different genomic tests out there, each designed to answer a little bit of a different question. Again, today I'm concentrating a little bit more on Oncotype and MammaPrint, but another one widely used, more so in Europe, is EndoPredict, and then a different test that answers a completely different question is something called the Breast Cancer Index, just to name a few. So what genomic assays are not, which is very important because I get this question a lot, these are not genetic tests. So this is not a test that looks at mutations passed on from mom or dad. So this is not whole genome sequencing to look at genes that make someone susceptible to cancer. Genetic tests can use blood, saliva, or other tissues, but what we're using in these genomic assays is the actual tumor itself. So even though they have the word gene in the test, it does not mean genetic testing. It means genomic, or looking at the DNA level of the cancer itself, and not what was passed on from your mom or dad. So it's used more commonly now in cancer treatments and aids in decision-making and treatment recommendations, but does not necessarily give us information on the biology of the cancer. That's genetic testing I'm talking about. So if we do a genetic test to look for BRCA1, BRCA2, it can aid in the decision-making for treatment, but it's not what we base giving chemo or not giving chemo on. So how do we incorporate genomic assays into treatment recommendations? So we know that disease-free and overall survival rates from breast cancer have increased steadily over the last several years, despite a trend towards less aggressive surgical techniques. Breast-conserving therapy represents the gold standard now, and even management of the axilla is increasingly more minimally invasive in cases of limited nodal disease. Enhanced understanding of the molecular basis of breast cancer allows targeting breast cancers with hormonal agents alone and or immunologic agents. The benefit of adjuvant chemotherapy is most apparent in cases when cancer can't be cured by local therapy. The application of chemotherapy is becoming increasingly individualized and over-treatment is avoided, which is why I'm highlighting genomic assays in general. International guidelines now include gene expression analysis or genomic assays to help us decide what the best treatment approach is for an individual patient. So it's in some ways personalized medicine, which is very different than 20, 30 years ago. So this is an ER stain. So this is an immunohistochemical stain on a breast tumor that's removed from a woman's body. So this tells us, yes, this is hormone positive breast cancer, and if we block this receptor, this may be helpful. But what this stain does not tell us is deeper down on a DNA level, the biology of the breast cancer, and if it has aggressive or non-aggressive genes that may lead us to avoid chemotherapy altogether. So this is where genomic assays have come into play. This is a cartoon demonstrating the ER and PR pathways of signaling leading to cancer growth. We know some genes in this cascade lead to more virulent growth and risk of metastasis, and some quite the opposite, show us that these breast cancers can be indolent and don't require the use of cytotoxic chemotherapy. So this is a pivotal paper that was written in 2000 and in Nature by Perot, and it really tells you a lot about what we do today in breast cancer. So I tell my patients, not all breast cancer is one size fits all. We currently know of 4 different subtypes of breast cancer that are treated very differently, and now I would say we probably are even learning more subtypes, but right now these are still the most common. So the luminal A and B are your hormone positive breast cancers. But luminal A, as you can see on, I think you're seeing it on the right side of your screen, this is a genomic analysis of these tumors, different types of tumor, whether they express hormones or they don't. So the luminal A and B in general have a more favorable prognosis than a HER2 positive breast cancer or triple negative. And we can see that on genomic sequencing. And so the genomic sequencing that Perot was able to demonstrate is that these 4 different subtypes have different outcomes depending on their treatment. We're going to focus mostly on luminal A and B because these are our hormone positive breast cancers. The third one down is ERBB2, which stands for HER2 positive breast cancer, which we won't be addressing today. And the basal-like breast cancers, which have yet a different genomic signal, are our triple negative breast cancers. So when this is applied clinically, this is one of the first clinical trials that looked at patients and how they were treated over time and how they did. So this is overall and relapse-free survival analysis of about 50 patients with breast cancer. And they were uniformly treated in a prospective study based on different gene expression classifications. So you can see that the purple and blue are that luminal A and B. Those are hormone positive breast cancers, followed by HER2 positive, followed by basal-like underneath. So you can see that the luminal A breast cancers, these strong expressions of estrogen and gene sequencing that shows a low growth, less aggressive breast cancers overall do much better than any of the other subtypes. So these are the patients we focus on when we're trying to determine, can this woman avoid chemotherapy? So this again goes back to 2000, 2001 and where all this data started to come from. So Oncotype was one of the first to market. It's a 21 gene sequence analysis. The genes you can see in these little yellow boxes, some are high-risk genes, some are low-risk genes. And the test is designed to analyze the tumor, tell us how much these genes are expressing, and then give a score. So this initially was designed with very early stage node negative hormone positive breast cancer. And it's also assumed that these women receive at least 5 years of endocrine blockade. So it's called the 21 gene recurrence score is how it's reported out. The score ranges from 0 to 100. And traditionally 0 to 18 was low risk, 18 to 30 was intermediate risk, and then above 30 was considered high risk. And we have had data over the years to say the low risk women can forego chemotherapy, the high risk women need chemotherapy, and we never really knew what to do with the in-betweens. But the prognosis for a very low, rate of distant recurrence is 2% at 10 years for these low risk. You can see, if my pointer shows up, that these low risk gene analysis tumors have a very favorable prognosis over time. And this is going out beyond 15, 16 years. So likely no effective chemotherapy here. So more recently, we tried to look definitively at that intermediate risk score and see if we could really hone out any women that needed chemotherapy in the intermediate risk, because we just weren't sure. So the intermediate risk, to remind you, is anywhere between 18 and 30. And this test was recently published in 2018 in New England Journal of Medicine. This is called the Taylor-X trial. And it was looking specifically at that intermediate risk group, trying to decide whether or not it was beneficial for women in this group with a mid-range score to receive chemotherapy or not. It was also done prospectively to confirm that a low risk score between 0 and 10 was associated with such a low rate of distant recurrence with endocrine therapy alone, and those women could absolutely forego chemotherapy. And what you can see on the graph that I'm showing here is that this is your intermediate risk group. There are caveats to this. This is the entire population, the intent to treat population. And you can see that the endocrine therapy, as well as the chemoendocrine therapy lines overlap. So no significant benefit from the addition of chemotherapy in most women, I would say, that score in the intermediate range. Now, that does depend on pre versus postmenopausal women, and that's when I talk about the fine tuning of the numbers, which takes a lot of discussion here. But for the most part, we know that women who score above a 20 can forego chemotherapy. So this is yet another just phenomenal evidence-based data that shows us that less can be more, and we continue to do that over time. So then moving on to a second test that we order a lot. This was based on MammaPrint, and MammaPrint is another gene analysis test or genomic assay test that looks at 70 genes. Now, 70 genes is not necessarily better than 21. They're just different genes. This is by a company called Agendia. This was a little bit of a different population that was studied. So these were high clinical risk patients. So bigger primary tumor, node positive, grade 3. They had some higher risk features, but were sent for these genomic analysis. And what we found is the women that had a low genomic score, but a high clinical risk, something that we would have typically given chemotherapy, overall did very well. So you can see on these graphs to the right that these were the high clinical risk, so just let's say a big tumor or node positive, but low genomic risk. So looking more like that luminal A subtype that I showed you that had almost a flat line, looking back at some of those nature studies. So by this, we know that about 40% of women that were included in this trial were able to forego chemotherapy. So again, backing off from treatment, coming up with even better outcomes. So the recent 7-year follow-up from our big national breast cancer data continues to show really good disease-free survival over 7 years out. So another good genomic assay, but a little bit of a different population that was studied. So what is the impact on treatment recommendations? So again, these tests are used predominantly in hormone positive disease. They can be used in node negative or positive disease, depending on how the physician is classifying you as clinically high or low risk. They can be predictive and prognostic for benefit of chemotherapy. So we actually get a score from these tests, and then your physician is able to tell you with almost complete certainty what the addition of survival or disease-free survival will be on your outcomes. It is now incorporated on our NCCN guidelines and ASCO guidelines, so it's very much a part of upfront decision-making. So in my practice, for me, at times, I use it to decide neoadjuvant therapy or not in cases where I feel like someone might have a more aggressive hormone positive breast cancer, and I may feel like there's a role for chemotherapy up front because I like that neoadjuvant window. Some assays can also clarify discordant pathology. So our routine path that we get, if you go back to that ER staining, we're simply doing a stain, looking at estrogen, progesterone, the growth rate, and that HER2 amplification if it's there. If there's any feeling that that doesn't make sense with the clinical presentation of the patient, or we have 2 biopsies that disagree, MammaPrint even has a part to it called Blueprint that can really tell us with almost with definitively where these patients fall in as far as luminal A, luminal B, basal-like, or HER2 driven. So it's able to tell us as a physician, you don't have to guess, here's kind of what we've got and here's why and how this tumor is growing. So for me, sometimes it can even give an idea of which chemotherapy will be better if needed, but these are special situations. So there are subtleties in premenopausal women, as I've alluded to. So their scores tend to shift a little bit. So a lower score may benefit them a little bit more than would in a postmenopausal woman. And that just has to do with the impact on ovarian suppression and the ovaries not working in a postmenopausal woman. So again, subtleties, and that's something I'm not necessarily going to get into today. And that is all I've got today.
Thank you so much, Dr. Robinson. Just a reminder to any viewers, if you have any questions, please put them in our comments section. We'll be happy to get those to Dr. Robinson. I had a couple of questions that kind of came to my mind as I was watching this. When you're looking at a tumor, how are you defining whether it's aggressive or slow growing? Is that something that's in the genomic assay, or is that something else?
So it can be in the genomic assay. I'm trying to get myself off of, I'm trying to stop sharing. It can be in the genomic assay, but when I'm looking at a routine path report from surgery or a biopsy, I'm looking at something called the grade. So how aggressive does it look under the microscope to the pathologist? And we grade that between 1 and 3. And I'm also looking at something called the Ki-67, which is an actual stain that can be done on cancer cells to tell us which one and how many are in active division. So the more cells that are dividing at any one time, the more aggressive a breast cancer. And it also, that plays into chemotherapy, because chemotherapy works on rapidly dividing or actively dividing cells. So the less cells that are in division, the cancer's not growing a lot, and the less likely we are to be able to make an impact with chemotherapy. So that gives me a lot of information. There are some nuances with how strongly estrogen and progesterone stain, but I think the grade and the Ki-67 are the first things I look at. Genomic assay, it doesn't really tell us the same thing about the grade and the Ki, but the Ki, in fact, the gene for that is encoded on the oncotype score. So there are proliferation genes in the genomic assay, and those are going to be either there or not there, and that weighs in on the final score. So someone I might be worried about is going to have a higher score on the actual genomic assay, which would confirm what I was thinking just by looking at the cancer. But as we see with MammaPrint, as 40% of women were able to avoid chemotherapy, even being high risk, named high risk by their patients, we know that genomics plays a bigger role than what we have traditionally looked at.
That makes sense. Thank you so much. You were talking about, avoiding chemotherapy, and that's one of the big pieces to this genomic assay. Can you explain for us a little bit more what are the benefits of avoiding chemotherapy? I think some people think, oh, cancer, hey, just blast it with everything you've got. But what would be the negatives to doing chemotherapy if you didn't have to?
Well, it depends, but chemotherapy is essentially poison at a controlled rate to kill malignant cells. So, of course, there are different comorbidities depending on the age. Some chemotherapies can affect the heart and lead to long-term toxicity and congestive heart failure. There is a potential 1 to 2% risk of developing what's called a treatment-related leukemia many years down the road if chemotherapy is undertaken. There's also psychological changes, emotional lability with depression and anxiety, cardiovascular risks when we start out suppressing the estrogen early on, and bone health, I would argue as well. Even without endocrine suppression, chemotherapy can cause bone loss in up to 30% of women. So it's not something I take lightly. It's a very detailed conversation, risk benefit with each individual woman.
Thank you. That was definitely enlightening. One of the things I wondered is, how long does it take for the genomic assay testing to come back? I know everybody's anxious when you have an initial cancer diagnosis. What's the time frame?
So it's about 2 weeks or 10 working days. The EndoPredict, one of their big selling points is that it comes back within a week. That may or may not always be true, but usually we can get that back a little faster. But the Oncotype and MammaPrint are about 2 weeks. And that is hard. I mean, 2 weeks is a long time to wait. But when we're looking for the right answer, some women prefer that versus jumping straight into something.
Thank you. Yeah. I guess the last question I had is, you were talking about mainly the two luminal subtypes, but I'm curious, are there trials working on the HER2 or the basal subtypes to be looking further at assays or treatment
No,
options?
USON or US Oncology actually has a trial currently called the FLEX trial, which is, again, mostly designed for hormone positive, but all women can get a mammoprint in that trial to help make chemotherapy decisions. Triple negative breast cancer and HER2 positive are also allowed to be enrolled in that trial. And it's a long-term follow-up to see, okay, so, you know, they scored this on their mammoprint. This is the treatment that was recommendation, and long-term outcomes are as such. So there are some remaining questions, you know, not so much in triple negative. We're learning more and more about those subtypes, but I think sometimes with HER2, we feel like we're over-treating some of those smaller tumors. And I think we'll gain some more information about outcomes in those women as well.
Thank you. That helps a lot. Well, it doesn't look like we've gotten any comments. It may be because Facebook is freezing. I'm not sure. So if you do have a question and we weren't able to see it, please feel free to write a comment. We can look at it at a later time and see if we can't get you an answer. So thank you to our viewers who are watching with us. And thank you, Dr. Robinson, so much. We really appreciate your time and expertise. This has been highly enlightening.
You bet. Me too. Thanks very much. Have a good day.
Thank you, everyone.